Professor Hussain Khan. He will be speaking on reproductive health research among tribal populations. He has been working for a long time on these matters. Methodological challenges. Yeah, please.
Honorable Chairman, distinguished colleagues, distinguished bureaucrats, research scholars, and my friends. At the outset, let me convey my gratitude to the organizers for having given me this opportunity to make my presentation, especially to Dr. Sharma, who took a lot of interest in calling all of us. Now I'll be giving a critique of the approaches and methods that are employed while they perform in the intervention programs, especially in the mother and child health programs. And I'll give a background first, a general background, then I'll go to a tribe called Kunubi tribe in Karnataka where work was done, and I'll take some snippets from there and try to illustrate the kind of lacunae which we see in the approaches. India presents a very paradoxical scenario in all sectors, including health. On the one hand, we have world-class hospitals with flourishing health tourism, best competitive doctors who in January 2015 conducted a successful heart transplant in an infant, which doctors in Germany could not do. But on the other, we find malnutrition among children and maternal deaths at an alarming rate in spite of maternal and child health programs since 1985. It is also to be noted that independent India in all these 70 years has not been able to meet either the objective of Alma Ata Declaration of Health for All by 2000 or the Millennium Developmental Goal 5 of reducing the maternal mortality by half by 2015. In other words, India as a nation is yet to come to grips with the various issues relating to health in general and reproductive mother and child health in particular. This is so despite the flagship missions of National Rural Health Mission, National Urban Health Mission, and so on. The worst affected section of the Indian population is the 8.6%, about 11 crore tribal people living in different regions. Perhaps, you know, India has the second largest population of tribes in the world. In these 70 years of independent India, in spite of 12 5-year plans and more than 40 and odd years of tribal sub-plans and the best constitutional provisions for the welfare of tribal population, and in spite of central and state level social welfare ministries, tribal welfare ministries, which include the component of tribal welfare, and several tribal development programs like ITDP, PECA, FRA, and in spite of several tribal research institutes, the tribal people in India are in a pathetic state. Recently submitted report, I am talking of Khaka report, of the Prime Minister appointed high-level committee on socio-economic, health and educational status of tribal communities in India 2014 has unambiguously brought out that the tribal people in India lag behind every other population in all indicators of human development, including health. A critical analysis of these efforts point out that fault lines lie in the approaches and perspectives that have been adopted. most of the programs relating to the tribal reproductive health are dictated by top-down, one-size-fits-all quantitative surveys and by what is called as the biomedical approach. Huge statistical quantitative data have been created at the national and state levels by such surveys as National Family Health Survey, National Sample Survey, Sample Registration Survey, District Level Health Survey, and so on. In health domain, these data may answer the question of what number, how many have fallen sick, or how many have died. Perhaps with this data, one can also project and predict as to how many may fall sick or die in the coming years. But when it comes to the question of why they fell sick, why and how they died, these data may not throw much light. Unless we know the answers to these questions of why and how, in addition to the question of what, one cannot frame or design a viable and effective intervention program to address the health issues. To accomplish this task, we need to depend complementarily on qualitative micro-level investigations of the actual lifestyles of communities and their social, cultural, ecological settings, which in actuality determine their behavior and activities. The other point is the approach of biomedicine. The biomedical approach runs as a common thread at all levels, be it policy making or formulating and designing health programs or implementation and evaluation of these programs. The language of biomedicine is culturally and historically constructed in the Western context. Mark Nichter, a very distinguished medical anthropologist from America, cannot be faulted when he almost said biomedicine is Western ethnomedicine. Biomedicine or modern medicine, as pointed out by Lindenbaum, Locke, and Gordon, is a product of Western biomedical and public health establishment. In biomedicine, culture and society are regarded simply as residual abstract categories. It depends on static, context-free individuals and epidemiological categories by focusing on clinical, proximate determinants of diseases and ailments. The secondary, non-biological, non-clinical determinants, though form the root causes, are relegated to the background. Hence, when it comes to the biomedical approach, the transmissible diseases, that is, in the case of transmissible diseases, preventing transmission takes precedence over helping persons prevent getting affected. In biomedical system, doctor is given more importance than the patient. Consistent with this paradigm, doctors tend to treat patients as having quote and unquote conditions rather than as social persons. The doctors consider their own observations of patients to be more valuable than the reports and explanations of patients. Quite often, doctors try technology for diagnosis and treatment and place relatively low value on talking with patients. They tend to give patients relatively little information and may at times do not listen to patients very well. In fine, the biomedical approach has been found to be narrow, top-down, target-oriented, wanting in user perspective. The modern health providers who depend entirely on biomedical approach treat people essentially as unvarying biological organisms bereft of socio-cultural dimensions. It is this biomedicine and its attendant technology as a major paradigm that virtually rules the diagnosis, treatment, pharmacopoeia in the domain of reproductive health programs in India. Research priorities and intervention programs in India are set by international organizations and are defined strictly in medical and public health terms. Hardly any attention is paid to ascertain and understand the several other reproductive health problems as people themselves perceive. This is exactly the reason why the domain of reproductive and sexual health, although includes several dimensions, the reproductive health programs in India do not go beyond maternity and childcare and to some extent prevention of HIV/AIDS. It is this perspective which has overshadowed several troublesome aspects of women's health, which have a critical bearing on health of females and males in their life cycle. The conditions such as reproductive tract infections, sexually transmitted diseases, cervical cancer, pelvic inflammatory diseases, unsafe abortions, uterine prolapse, tumor in uterus, urinogenital disorders, adolescent anxieties and curiosities, and also the problem of infertility do not figure in the program of reproductive health, though these issues have multi-dimensional bearing on the health of females and males in the rural and tribal populations in India. These issues have been largely ignored in the public healthcare initiatives and service delivery system. In fact, these reproductive morbidities the women undergo and endure in what Dixon Muller called as culture of silence. Even in the case of maternity and childcare, which gain predominant attention in reproductive health programs, there is no indication that biomedical healthcare, without adequate understanding of people's life ways and without emphasis on the minimum infrastructural facilities on the ground, has made dent in the reproductive and child health status of women and children in tribal areas. Given the common problems in the resource-poor settings in tribal areas like shortage or nil electricity supplies, medication, aseptic conditions, and qualified personnel, safe hospital births in the public sector facilities is not guaranteed. Indeed, many ethnographic studies in medical anthropology vouches to this fact. I have taken an ethnopediatric study of a tribe called Kunubi tribe in northwestern Karnataka to illustrate this point. I would like to narrate a few snippets of modern childcare provided by the government health providers. Kunubi tribe lives in Uttara Kannada district in the forest of northwestern hilly region of Karnataka. They claim that they are migrants from Goa more than 100 years ago. They originally followed slash and burn cultivation. Kunubi have their own language, which is more related to Konkani than Kannada. The other people who live in this region are the Kannada-speaking Havik Brahmins and Karivakkalu Gaudru, who claim nativity of this place. Most of the Kunubi settlements are in interior forests where there are no roads and paths are often very narrow. The number of houses in a typical Kunubi settlement ranges from 3 to 11 houses. Their economy is a subsistence economy. Agriculture labor is their primary source. Though staple food is rice, they hunt small animals, birds with the help of bow and stones, and catch fish from streams to supplement their food requirement. Kunubi social organization is built around patrilineal principles of patrilineal descent, patrilineal inheritance. They have exogamous gotri and prefer to marry relatives, especially cross cousins. Kunubi practice bride price and paid in the form of rice. They practice local residence and live in joint families till their grandchildren come of age and marry. Kunubi are afraid of strangers. They rarely go out of the settlements unless there is an health emergency like delivery complication or when a person has developed serious health problem. They go to the hospitals nearby. that to walking. There is no proper transport. They go to the doctors in PHC or to the doctors of private clinics in a nearby place, only as a last resort. They depend entirely on their indigenous medical practices and traditional healers. Kunubi are ancestor worshippers and believe in benevolent as well as malevolent supernatural powers. In all the maternal and child health programs focused on the Kunubi people, the frontline workers are the ANM, the Asha, and the Anganwadi worker. It is they who maintain first-hand contact with the Kunubi individuals and are supposed to keep track of their health problems. However, what has been found is that the approach of these ground level workers is more record oriented than people oriented. Maintenance of records is given more importance than the serious practical problems in accessing settlements, communicating with the people, and creating awareness. In other words, the children and mothers become mere numbers rather than individuals with specific needs. This can be brought out vividly through the narration of how the immunization programs operate and how the distribution of iron folic acid tablets are done to the pregnant women. ANM provides the iron folic acid tablets. They call it as tonic guligi, the tonic tablets, on the basis of physical examinations like testing the eyes and nails. Pregnant woman is told to consume iron folic acid tablets regularly without fail. ANM explains to the woman about the need of taking IFA tablets. She says that there is a need for pregnant women to consume iron folic acid tablets because they help the baby to grow properly in the uterus. Further, their consumption prevents complications at childbirth. But what the pregnant women do is that they do not consume the IFA tablets because of the belief associated with the fear that tablets will lead to the overgrowth of the fetus. Since the tablets are said to be for the fetus, for the growth and of the fetus, they would not want to consume them. They fear that if infant grows big, as a result of overgrowth, it will result in a difficult labor and the delivery is said to become complicated. Also, there is no concept of anemia among the people. Anemia can be equated with weakness as used by the people. Weakness is seen as something naturally occurring among the people, whether one is pregnant or not. It is associated with extra work, continuous activities without taking rest, and also, in case of pregnancy, a natural consequence of the woman being pregnant. Though they take IFA tablets from the ANM, they just keep them in the house or take one or two when they feel tired or throw them away. ANM also knows that the people do not take the tablets. She says the people are ignorant and imprudent and do not consume the tablets even though she tells them to. Although the Kunubi know about the importance of supplementary nutrition to the mother during the postpartum period for the baby as well as the mother, their perceptions do not match with the textbook advice and instructions given by the ground level workers like ANM, ASHA, and Anganwadi workers. They tell them to consume milk, fruits, and vegetables, hardly taking cognizance of the local realities. The non-availability of milk, the local food habits of consuming locally available vegetables, fish and meat of hunted animals, and their beliefs about the nutritional value of these foods are completely ignored. The gap between health providers and the tribal people gets further pronounced when it comes to institutional deliveries. Only in a complicated situation, the Kunubi women go to the government health centers and hospitals for delivery. Even in such situations, the difficulty in accessing these services and people's inability to afford expenditure on transport and tips to the hospital staff prevents them, resulting in disastrous consequences. In the normal circumstances, the Kunubi women prefer to deliver at home with the help of experienced old women who are really readily available in their neighborhood. They also express aversion to hospital settings because no one from the family is allowed to be by the bedside of the woman at the time of delivery, which is contrary to what happens in the home atmosphere. Disposal of the placenta is another reason for not opting for hospital delivery. The placenta is accorded enormous significance by the Kunubi. This sensitivity is completely ignored in the hospital environs. Immunization of children is the cornerstone of integrated child development programs since decades. Of late, realizing the failure of the earlier attempt, the government has come forward with the Blitzkrieg Indradhanush campaign on war footing with a goal to attain 100% immunization of children. However, so far, the ground realities of tribal people have seldom been addressed by the health providers. Kunubi provides an ideal case to highlight how immunization of children, even after several decades, is perceived by the Kunubi just as an injection, chuchu maddu, that's what they call, which they think are given by the doctors to sick individuals, not to healthy individuals. Kunubi do not figure out as to why the same injections, chuchu maddu, are given several times when the children do not suffer from any ailment. This lack of awareness casts shadow on the functioning of the ground level health workers. In this scenario, many tribal children go unimmunized. Besides the semantic difficulties, the health providers not being sensitive to the routine life of the local people and their subsistence livelihood patterns, this forms the major obstacle in the effective implementation of immunization program. Many a time the message regarding the date and timing of immunization does not reach the families where eligible children are to be immunized. This plight of the tribal children leaves one wondering whether the WHO certified status of India being polio free is going to be short-lived. Anganwadis are the main centers of modern health facilities for the people, especially mother and children in the tribal areas. But the criteria of establishing one Anganwadi for every 300 people, sometimes by clubbing villages when they have smaller populations, has been inoperative in the case of Kunubi tribe. Precisely because Kunubi live in small settlements. Each Kunubi settlement generally consists of 3 to 6 households consisting of about 20 to 25 individuals. Moreover, these settlements are scattered in the forest and hilly terrain. Such being the situation, it becomes difficult for the mothers and children to go to Anganwadi, walking about 4 to 5 kilometers to avail the maternal and child health services. Even helper in Anganwadi is unable to fetch the children daily from different settlements. It becomes further impracticable during rainy season when rough paths become slippery with leeches all around. Small settlements of Kunubi also constitute a problem to set up Anganwadi because of the absence of beneficiaries after a period of time. There is one settlement called Benagule settlement, which has 8 Kunubi houses. Illustrate this point. After 8 years of the establishment of Anganwadi in this settlement, there were no children in the age group of 0 to 6. The children were grown up, and until they married and begot children, there would be neither a pregnant woman nor children to be served. Then use of people's language is very crucial. Use of people's language in interaction between health providers and the targeted people has a very crucial role in bringing about change in the people's health-seeking behavior. Kunubi tribe have their own distinct dialect and are not well-versed with Kannada, which is spoken by the health providers. With this asymmetry, the imparting of knowledge about the benefits of the child health programs becomes one-sided because people do not understand most of what is said about the programs, and therefore they are unable to seek clarifications for the doubts and apprehensions that arise in their minds about the programs. In this scenario of communication deficit, the creation of awareness about child health gets severely affected. Rather, awareness is hardly created. In this study, what we have found is that there is a clash between two models of healthcare. One is culture-specific, indigenous system of the tribal people, which is easy to understand, more affordable, easily accessible, and socially secure. And the other is the modern biomedical system of healthcare provided by the government agencies and their personnel, including the locally available allopathic doctors. As far as local people are concerned, this is alien, not easy to understand, not easily accessible, not affordable, and is used only as a last resort when all hopes diminish. In this clash, many individuals in the program targeted population end up without getting served. In fact, this clash forms the crux of the present paradox in the Indian health scenario, wherein the best institutions of healthcare exist alongside the high levels of malnutrition and morbidities. Another point of concern is the inherent assumption on the part of the biomedical personnel that the indigenous practices are totally irrational, bad, and do not do any good to the people. Hence, the modern healthcare providers intend to impose the biomedical system and aim at eliminating the traditional system. On the contrary, the tribal people would not like to or prefer to part with the time-tested traditional system, but at the same time, they are not completely averse to the modern system either. They do accept modern healthcare as and when they get convinced about its benefit, but do not prefer to adopt it wholesale because of their incomplete understanding and lack of clarity. The process of acceptance and non-acceptance in the due course of time crystallizes into a mix of both systems, forming a unique pluralistic pattern to the specific setting and context of the people. Another finding. Kunubi people feel desperately afraid when they do not understand the origin and process of illness. But once they understand, they feel comfortable to face the treatment and its outcome. This is exactly what happens in the local methods of treatment by indigenous practitioners. The indigenous practices for the well-being of the mother and child are taken care of through different restrictions and observances, whether they are with regard to food or with regard to physical activities. taboos play a crucial role. These taboos are present at the stage before pregnancy, during pregnancy, and after pregnancy. The beliefs behind taboos play a significant role in acceptance and non-acceptance of modern maternal and child health services. Several micro-level studies point out that it is these nuances which hinder the implementation of the reproductive health programs. One of the main reasons for the ineffective implementation of the program is the paternalistic perspective of the health personnel and policymakers. The view that people's beliefs and value systems hinder their development, and that they are unable to understand the importance of the programs, and that they stick to their system and not ready to change, that their lifestyle is detrimental to themselves, are some of the templates that rule the thinkers and policymakers of tribal programs. Unless they abandon this ethnocentrism and strive to vibe with the perspectives of the people, there cannot be worthwhile, effective implementation of the programs. So this is just an example. I've tried to say that the kind of gaps which we find in this particular tribal context has also been found in a different way in other tribes, like the beliefs about iron folic acid tablets or about eating papaya and so on, have been found to be varying from place to place within Karnataka among several tribes. So ultimately what I have tried to say is that there is a need for reorienting the perspectives and approaches as regards to the ground level workers are concerned more than anybody else. Thank you for having given me this opportunity.
More or less is the same scenario everywhere in all things, and that is why there is a demand for a national or separate tribal health policy, not in national tribal policy, but tribal health policy. There is a demand for that. Of course, Northeast is a different issue. As you said about this iron tablets, not only that, the tribal women eat less. I mean, they should eat, of course, more for the two, as we say, because of the problem of this difficult labor. You will find the statistics never comes out. There is less maternal mortality among tribal people as compared to others. But of course, infant mortality, neonatal mortality is very high. We can't put a cause-effect relationship, but maternal mortality is not financially affordable, because there is a bride price. If I want to have a wife, I have to pay for it. As you know, it's opposite dowry. So there would be no system whereby a woman should die. If she runs away, okay, she will pay the bride price again back. That's a different issue. I mean, we have not done studies on these, anthropologists have not really done studies in depth on all these issues. But these are all the issues which are there. One more comment about you. When you take about grassroots level and all that, even at the national level, who is running the public health? Not the doctors. These are all the paramedics, ANMs and ASHAs and all that. And you will find people asking for more medical colleges. There should be more institutes of paramedics. What the doctors do? Doctors only do sit in OPD. Whether he is a Ayush doctor or a modern doctor or anybody, then who goes to the house of the person? Does ever doctor go? He goes only by invitation, and for which he has to be paid separately. So these are the issues, which are not taken into policy issues at all, at the grassroots level as well as the national level.